عليكم. جدا اسف تاخرت عليكم، لكن مين هنا مصدق؟ Who has a headache? Who has a migraine? Yeah, so who's diagnosed with migraine? Okay, so um, generally everyone, those with migraine and without migraine. If I told you that I can give you an IV treatment for migraine, would you take it? Why not just take the oral medications that we have now? It doesn't work because the IV almost, that's research, but it tells you almost 100%. But you're all willing to take an IV? Huh? If you have a very severe migraine, it's not working. You're not scared of the IV. IV medications are strong medications, and
it depends on how long the treatment lasts.
30 minutes. But you're not scared from an IV. Okay. So and I was on the phone because we're bringing a new medication for migraine. It works beautifully for migraine. It's an IV once every 3 months. So the patient doesn't take pills in their pockets. Patients with migraine who has very severe migraine, they would have pain medication in their pocket, pain medication in their wallet, pain medication in their drawers in the office, pain medication in their bags, because they need to escape. And that's a horrible quality of life. Even if they have one attack, the month is ruined for them. So now imagine you just take it once per 3 months. So that's once 3 months, that's 4 times a year. That's a huge thing. Plus, it's amazing. It works amazingly. We're going to bring it, but I noticed that the young population, they are very willing and ready to take the IV. Whereas the elderly population, as in people 45 and above, and they're not elderly, but adults 45 and above and have history of taking medications, they don't want to go to the IV because it's a strong medication. It's nice to see that mindset.
No side effects?
The new medications for migraine usually have almost no side effects. And it's a monoclonal antibody. It goes to a very specific place, so it doesn't really cause a general effect. As opposed to the previous medications, they are general medications, so they would help the migraine and do other stuff.
Is it already approved?
It's called Vyepti. It's already approved. I feel like a farmer rep. It's approved for the last 5 years. It recently arrived to Saudi Arabia for the last year, and we're trying to bring it to King Faisal. However, it's kind of expensive. It's 3,000 every 3 months, which is, if you don't have insurance, if you're not Alhamdulillah, Saudi, it might be easier, but in other populations, 3,000 is a heavy amount every month. Right, now we'll go back to our lecture. So last time we had the steps to neuroimaging. We'll now apply it to a clinical case. So we'll start with stroke. What does stroke mean? Ischemia to the part of the brain. So is it always ischemia? What can it also be? Hemorrhage. So it's ischemia or hemorrhage to the part of the brain. So let's try to evolve that definition. So what also happens? So I have ischemia or hemorrhage. How is it caused? Lack of blood flow. So lack of blood flow can happen. How? What's the type of lack of blood flow? Embolus or thrombus or hemorrhage. So the vessel will bleed. So it's either blocked or bleeding. So the flow of blood stopped because it's either blocked or it's bleeding out and it's not going to the other direction. And then at the end, it would cause to the brain tissue ischemia, but we also call it hyperperfusion, lack of blood flow because it's not being perfused, and then that tissue would die. So always start with a definition for everything that you're working with. Ischemic stroke is an episode of neurological dysfunction due to focal infarction in the central nervous system, attributed to the atrial arterial thrombosis, embolization, or critical hyperperfusion. While ischemic stroke is formally defined including the brain, spinal cord, and retina, in common usage mainly refers to infarction. So you can have stroke in the spine, you can have stroke in the eyes as well. But now we're just when we say stroke, we're just talking about the brain for today's lecture. Like case number 1, who wants to go with the case? Go ahead.
Elderly patient coming with sudden lower limb weakness for the upper limb and sphincter bladder control.
Okay, so you have a patient who came in suddenly, which is the key feature here. Okay, and he's in the bed in the ER. Immediately you go see the patient and you're noticing when you ask them to raise or you're testing the strength of the upper arm, we call it out of 5. The arm is 4 out of 5, but the leg is 3 out of 5. So there's a clear right-sided weakness, but the leg is more than the arm. And then you also notice that they're having trouble controlling their bladder. Okay, since this is a stroke lecture, you studied the anatomy of the brain, anterior, posterior, medial, MCA, ACA, PCA. So technically, what kind of brain territory is this picture from? Is it ACA, PCA? Okay, why is it ACA?
Supplies the homunculus.
Okay,
The ACA supplies the medial aspect, which is
okay. So because of the homunculus, you have more of the leg, so you have more lower limb weakness. And why do you have a sphincter control issue then?
I think
Hmm?
I think also on the same side of the homunculus there is
So generally, the the nerve supply for the bladder would be around the anterior or the frontal region, but at the same time, the frontal region is responsible for disinhibition or inhibition. So when you want to think, uh, attention, all of that's into the frontal lobe. So when you have dysfunction or issues with the frontal lobe, you have more inhibition. So or more disinhibition. So you cannot really focus or be attentive. So part of that is because of the nerve supply to the bladder, but at the same time because the brain cannot have enough attention to hold the bladder. Because the bladder, when it relaxes, it releases the urine. So it has to have this tense presence. So when you have inattention, it's easy to relax the bladder. This is the image for an ACA. Is this a CT or MRI? MRI, because you don't see the bone and you see a very clear brain structure. But this is also less clear. So this is also a DWI because you can see clearly lighting up of the lesion. Usually when we do imaging of the stroke, we look at the CT of the brain and then angiogram because we want to see the vessels, but we also, in the MRI, we do DWI, diffusion weighted restricted image, because we want to look at the flow of the fluid between broken blood-brain barriers, because the stroke would basically destroy the blood-brain barrier and it would have flow of fluid around it. And DWI, most importantly, tells me the age of the stroke. If it's acute, if it's a few hours, it's a few days. Okay, so this is an ACA, and as you can see, ACA is medial and takes a very linear shape, and it's not a massive stroke. It's usually very clean stroke in one linear medial side of the brain. Second case. Go ahead.
Case 2. An elderly patient coming with a sudden contralateral arm
Weakness.
confrontational numbness, contra weakness, gaze deviation towards the affected side.
This is a mistake opposite to the affected side. So you have a full side, let's say right side, fully weak from movement or power and weak from sensory, as well as you have the eyes looking at the other side. Okay, so which one is this? ACA, PCA, MCA? So who says MCA? Who says PCA? So you say PCA because of the eyes, right? So the eyes technically is with the vision. If there's an issue with the vision, you would call it more of a PCA. Okay, if there's an issue with the movement, just to make it easier, this is part of the MCA because you have stuck eyes rather than an issue with the eyes. Yeah, because it's part of the neural network for how the eyes are moving conjugated, and when you have a lesion there, it's going to stop or get the eyes to be stuck in one side because the other signal is gone, so it can't really go to the other side, so it gets stuck on one side. And you have a massive right-sided weakness and low affecting the power and the sensory. So something this huge taking a big portion is usually the MCA, middle. And as you can see here, the MCA usually is a large chunk of the brain. Okay, is this a CT or MRI? CT, because you can see the bone. Okay, and what do we call this lesion? How do you describe it? Hypodensity. Okay, so this is a hypodense lesion. Okay, and that signifies that unfortunately it's dead tissue. And this is how you see the MCA. It's a large part lateral of the brain. And this is how you see it in the, what do you call this? Angiogram, CT or MRI? CT, because you can see the bone. Okay, and angio because it's the arteries. You can see it's the blockage starts here. And the easiest thing is that we always said that the brain is symmetrical. So here, if you see this one going down and bifurcates, you can see this one going down and bifurcates. So this area is fine. But if you see it here, this goes out and it bifurcates and moves into different locations. This stops and it doesn't move. So this is a very black sea of no vessels. But around it, you can see vasculature, which is basically the collaterals that support this region as much as possible. Case number 3. Go ahead.
An elderly patient coming with a sudden homonymous heminopsia and having sensory loss.
So what does homonymous heminopsia mean?
Can't see on the same side.
Yeah. Homonymous, both eyes, and hemi is one-sided. And hemisensory loss, so one-sided sensory regions. So it's more sensory than power or weakness. And it has a vision cut. So here we go into PCA. And this is how the PCA appears. It's similar to the anterior. It's a linear medially, but instead of the anterior portion, it's in the posterior portion. Sometimes the PCA is less defined than other strokes. As you can see here, it's there, but if you're not really focused and you're going through the slides real quick, you might miss it. So it's very important to localize or find it in this image. Who remembers what this is called? So this is the insula, but this fissure is called Sylvian fissure. Okay, and we use the Sylvian fissure to demarcate the hallmark and tells us which lobe. That's the central sulcus. So the central sulcus, lateral sulcus, and we have the Sylvian fissure. So Sylvian fissure tells you the temporal lobe. So this tells you below it is a temporal lobe. And this is very important to know, the insular region as well. We'll get back to this. Final case. Who would like to take it? Final case is difficult. Ready? What is this?
This is an MRI.
So this is MRI. Hyperintense lesions. Try to describe them more. Try to tell me what you're seeing. Without me seeing the image, I would imagine it.
So some of them are paraventricular.
Okay.
And the rest are scattered throughout the cortex. So you say juxtacortical.
You can say juxtacortical, but generally it's juxtacortical. It's paraventricular, so it's scattered. Let's just use the word scattered here. Hyperintensities, but give me more description.
That's both sides.
Both sides.
That means like big arteries.
Yes, it's a big artery. So it came from. So the right and the left, they have separate blood supplies. Huh? So it's not. Doesn't make sense that it came from the right and the left at the same time. So you go back until you reach a main artery. Exactly. So that's where a big lesion, stroke comes from main artery. Or if you go back even more, where would you go to? So the heart. So the heart would have some clots, and when they did dislodge, they'll become emboli and go through the internal carotid, and then they would go up. So why does it scatter everywhere, as you mentioned? Because we call this showering. So it's like a firework. Firework goes up, and then blast, and you have different things. So it goes out of the heart, it goes up, and when it hits the bifurcation, it's becomes small pieces, and it goes all around the brain. So this is very important to note when you find this. Usually this is a patient with a very bad cardiac disease, or a patient that is post-surgical for a cardiac case. Any internal carotid manipulation or cardiac manipulation, it can dislodge one of the clots. And when the clot is dislodged, it goes up and then shatters and showers everywhere else. So it's very important to note that when you see this, this is basically telling you that the patient is having clots in the heart, or less commonly in the internal carotid. But this definitely screams cardiac disease in a very bad way. Now, what other cardiac diseases can cause a stroke? Arrhythmias, abnormal walls, ventricular fibrillation. So any abnormal rhythm, what would it cause? So how would it cause a stroke?
Decrease blood ejection.
Okay. So you're saying that less blood is going to go to the brain, but not enough to stroke. So that's a good way of thinking about it.
Usually for diseases like, let's say for example, AFib, it's a classic disease that can cause
Exactly.
stroke. The heart pumps in a weird way where blood like 12 factors merge together, cause a clot. That clot can dislodge and go on.
Okay, so remember the triad? The hypercoagulation or coagulation triad? Virtuous triad. What is the triad?
Stasis,
Okay.
hypercoagulability,
Uh-huh.
and endothelial.
Okay, so if one of these three is affected, you would have a clot developed. So in an arrhythmia, which one of them is stasis? So the blood flow is going to be disrupted because the blood is not pumping efficiently. So any type of arrhythmia, especially AFib, can cause strokes. And it's one of the major things that we need to look for when we have, especially when we see this picture. Now you mentioned walls. What is the wall deficit or defect that we want to look for? Cardiac wall defect. Upper traffic wall. It doesn't really cause stroke, but it's a defect.
VSD,
VSD, what else? Regurgitation would cause plays with the stasis of the blood. Because I want the wall defect. So other than VSD,
could it be stenosis?
so anything that will play with the flow of the blood, stenosis, arrhythmias, valve issues, it would cause stasis issues. Because walls. Vasculitis is when the vessel itself is disrupted, so it would cause endothelial issues, and that would form clots, or it would cause strictures because it's inflamed, so it becomes smaller. Because now we're talking about the heart and the walls of the heart. We have VSD, but we also have
What if it's a pericardial?
some
Pericardial effusion.
pericardial effusion. Doesn't really cause strokes. Then it's a momentary disease, so you have to treat it. And if it's gone, it really doesn't disrupt the flow of the blood that much.
There is something that happens with kids where there is a shunt between the two.
Yeah, that one. What's it called?
Is it both Parkinson White?
Wolf Parkinson White is an arrhythmia, and it's more in an adult population.
It's in foramen valve.
Exactly, PFO. PFO is very, very important because when you have coagulation, if you remember the blood flow, the arteries then goes to the venous system and everything else. The only direct way to the brain is different from the rest of the body. But if you have a PFO, which is an opening, a venous clot can go through the PFO and immediately go to the brain. So what's the most common venous clots that we need to look for? Deep vein thrombosis. So an elderly population or patients with risk of DVTs, which is unfortunately a common thing, if that clot dislodges from the venous system, it will go up, enter through the PFO, and go up. So how much of the population has a PFO? How many people in the population have PFO? Rare, common, 10, 50. Rare as in how much? 5%. Mean easy. 10%. Even more. 15, even more. 25%. So and here we're about 30 people. So about 7 of us have PFOs. So does that mean we all 7 of us have to close our PFOs? So what would make me decide to close it or not?
If you have a coagulation issue.
Or in a different sense, a risk factor, coagulation and others. So we have something called the rope score, rope from the rope. And this rope score tells you how much of a risk you have of the PFO being cause of the stroke or not. Okay, so now we notice that we're talking about how a stroke happens and why a stroke happens. We know how it looks like, clinically and radiologically. But when we look at the TOAST classification, it tells us where or what is the mechanism of stroke most likely. We have a large artery, which can be atherosclerosis, can be emboli, can be thrombus, something just clogged and stopped the blood flow, as simple as that. Or we have a cardioembolism where it originated from the heart, not just from anywhere in the system, and we need to look at the heart and fix it. Or we have a small vessel occlusion, or we call it lacoon. So lacoon is this, when we go subcortically in a very small, fine vessels, these vessels would start to be eaten up or disrupted, and then the blood flow would be less. And technically, these small vessels are too small to have an emboli and thrombus. So what would cause a stroke with these small vessels? Rupture, but how would they rupture? Hypertension, diabetes, and cholesterol. So these small vessels, that's why also in diabetes you have diabetic foot, because diabetes would create less nutrition to the vessels, would cause some microvascular issues, and then the small vessel will start to die out slowly. And then you would have increased risk of developing small vessels. And this is important to know because when you know the cause from the classification, TOS classification, you know how to deal with a stroke so it doesn't happen again. So here I treat the heart, here I would treat the coagulation, here I would treat the chronic diseases. And then you have stroke of determined and undetermined etiology. Usually the PFO lands here, and other things such as stroke in young with the with the genetic predisposition to coagulation and such, or systemic disease that increase the risk of coagulation. Now the cases are done. We know how it looks clinically. We know how to look at it radiologically, and we know the concept behind the stroke. Now I'm going to show you just a few images, and we'll discuss them, and that will be, inshallah, the main lesson for the strokes. So this is the main MCA. MCA has the main MCA, and then it branches out into 3 branches. The main MCA takes a big chunk of the brain, but then when you go to the anterior MCA, it takes only the anterior portion. The middle would take the middle portion, and then the posterior, it's going to take the posterior portion. And when we mentioned the clinical presentation of MCA, the MCA is a large portion, so you will have a large deficit on one side. But the more distal the stroke is or the clot is, the less the surface area is affected. So you will have more of a focused presentation of stroke. So it's not going to be a large stroke, but it's going to be a focused stroke. So an anterior is different than a middle, than a posterior. You really don't need to know how they present. You just need to know that the MCA in general would have a large one-sided deficit. We mentioned the PCA. Again, it's similar to the ACA, medially and linear presentation, but it's in the posterior aspect. And the ACA, we just mentioned it. And this is the perforators or the lacunae or the small vessels. They're usually subcortical and small structures of the brain, and they take small vessels. And this is another way of looking at it. This is the anterior, this is the posterior, this is the small vessels, and then this is the MCA region. Sometimes when you have not a stroke or a coagulation, but you have an issue with how the blood supply is moving, and that's more of a hypoperfusion. So you have diseases of the heart, or when you have the patient is bleeding or the patient is under surgery, less blood is flowing up. So there's no clot, there's no blockage, there's no stricture, there's no hemorrhage. But the blood is flowing less than before, less efficiently than before. So you would have something we call watershed regions. You can see them here. It might be difficult to see on the screen, but it's there when you look at the presentation. And that's basically an intersection between 2 ACA and MCA, or the PCA MCA, because the flow of blood is not enough to reach the end. So they reach 80% of the vasculature, and the 20% at the end, the flow is too weak to reach, so it just doesn't get there. And this tells you that the patient is too hypotensive, or the patient has a complicated surgery.
And it also looks like the watershed is symmetrical.
It's in between 2 areas. So it will be here, it will be here, it will be here. So it can be one of them, it can be both, it can be, but the point is it's going to be between 2 territories, between the PCA and MCA and such.
The right hand.
It's going to be one-sided. Then I usually have both ICAs, but in one region, not everyone's right and left vasculature is as efficient. That's why in the elderly population, one of the screenings is we see the ICAs. This will be 60, this will be 100, for example. We have a patient who had him and his wife were joking, and she strangled him as a joke. Yeah. And he said, we were just laughing, and and then suddenly my right side stopped working. Then when we did the screening, he had this was almost blocked. It was 90%, very, very blocked. And this basically needs intervention right away. Always be careful from your wives. Small joke. Anyway, ندخل على 7 signs of early stroke. So stroke can appear clearly as we just saw here. But sometimes we want to catch the stroke as early on. Now we live in a alhamdulillah, very good quality healthcare. We can reach hospitals easily, and people can identify when something is wrong. So, by definition, most likely the patient is going to come really fast to the hospital. We know that these things, hyperdensities, they show up later after a few hours. 3, 4, 5, 6 hours, you would start to develop the blackness and the tissue would start to die out. But before, it's not going to be that clear. So how can we notice if the patient is having a stroke or not? Number one rule, clinically, if it's a stroke, it's a stroke. You just need to do a CT to see if there's no bleed, because a normal CT does not rule out stroke. But we do a CT just to make sure there's no bleeding, because if there's bleeding, you cannot do thrombolysis and such. Now, number one sign, of course, is hypodensity. You always need to look for hypodensity. No matter what the age that it looks like in the CT, sometimes it can be reversible. But also, I want you to know the loss of gray-white matter differentiation. So when you look at the sulci, you can notice that this is the white, this is the gray, this is the white, this is the gray. And as you go down, you would start to notice that it's not really, you lose the demarcation. So the white and the gray go into each other. So that's sign number 2. Sign number 3 is hyperdense MCA sign. So when there's a blockage, the blood has abscesses. Blood flows slow in this region. So it starts to light up. And this is basically, and the clot is early, so it's a fresh clot. So the fresh clot lights up. So when you see the image, you don't see hypodensities, you don't see signs of stroke, but you do see the MCA lighting up. And that tells you that this is a clot, and you need to act fast to remove that clot. 4th and 5th sign, the insula, that's why I showed you, the insula here, it starts to disappear. So you see it here, but here it doesn't appear, because there's a stroke that is actively evolving, and there's edema around it. The brain is trying to protect that region, and then it pushes the insula and the sulci around it, and they lose this area as well. Basal ganglia as well also disappears because the area of edema around this lesion. And then number 6, you have the sulcal effacement, again due to the edema. The sulci starts to disappear. And then finally you have ventricular compression, again because of the edema, it pushes the brain a little bit. So these are the 7 signs of hypodensity, of early stroke. Now, where is this stroke here? Or where is the blockage? MCA, right or left?
Right.
Agree? Okay, as we mentioned last lecture, please don't mix up right and left. Because in the exam, you're going to get a very simple question. You're going to see an image, and this image is going to tell you that there is an MCA lead stroke on the right side, MCA stroke on the left side. You have to choose one of them. Always, when you're seeing the image, the patient is opposite to you, so your right is the left and the left is the right. Okay? So this is another way of just showing you the DWI and just the stroke imaging. Ignore that this is bilateral. Then there's some vessels can develop bilateral anterior ACA. You don't need to know that. But I'm just showing you how linear and how medial the anterior stroke is. And this is the MCA and this is the PCA. But the DWI, we talk about it a lot, not because it helps us see in the stroke clearly, but it also tells us the age. As you can see here, acute, 24 hours, 7 days, and 30 days. It can tell me how the age of the stroke is, and it changes in the amount of diffusion, and this also helps clarify the age of the stroke. And this is very important because clinically I need to know the age of the stroke to know how to play with my antiplatelet and anticoagulation depending on the cause of the stroke. This is another image of the stroke that you can see here, but I also want you to notice that it's also causing some edema. So when you see a large stroke, always look for edema. And usually a stroke, this is an MCA stroke, okay? When you see an MCA stroke and you admit the patient, you have to look for things or keep things in mind. So what can happen in the next 5 days? Number one, the most common thing is headache because there's edema growing and then edema going away. The more the edema, the more the headache. And then the edema goes away after 5 days and he's feeling fine. The second thing is the risk of restroke. There's a possibility that the patient strokes again. So you have to check for the risk factors if the patient is high risk or low risk to stroke again. This is something in the past. We don't have it alhamdulillah anymore now because we're more efficient in how we handle stroke. But the third and most important thing is something called malignant MCA. So malignant MCA is because the MCA takes a large portion of the brain. It is a lot of dead tissue. So any change or manipulation of pressure would start to hit that dead tissue, and it's going to start to tear. And we have tears in this tissue, it will start to bleed. And then you're going to have a horrible thing called malignant MCA, which will be this. So this was the MCA that I showed you, and this is after it's bled. So I honestly don't know unless the patient suddenly crashes, and then you take him to the CT, you see this, you immediately take him to the OR, and you put an EBD to take out the blood. So it's a huge storm of blood because there's a big area of dead tissue. Okay, and when you have that in a malignant MCA, or when you have a patient who has an ICH or intracerebral hemorrhage, as in a stroke that was started by hemorrhage, you would have bleeds. So this is a patient who has a stroke, but when you did a CT, you found that it's a hemorrhagic stroke, not a ischemic stroke. So it started because of a bleed. And this is how it appears. Again, pathologically, the blood is destructive and tears the brain apart. So it's very important to heal it as fast as possible. Previously, we would just adjust the blood pressure and hope that the bleed would slowly be absorbed by the brain. And that's how we used to do it. Now we have something very cool. It's called scuba technique. Ever heard about the scuba technique? So GI, they have a scope. So they go in and they do whatever they need to do with the GI system. Now imagine if we do a small hole and we do the same scope, we go into the brain, go around, look for the blood, take out the blood, then leave. Exactly like a GI bleed, but in the brain. Makes sense, huh? So that's something very cool. It's being done in Mount Sinai in New York. Inshallah, we're going to start doing it in King Faisal as well. Because again, blood is destructive, and we need to, as much as possible, take out the blood as fast as possible. And these are the new ways of dealing with the bleed. Because previously, we just hope that the bleed would start to dry up on itself, and it usually does dry up because you stop the bleed. But at the same time, if it evolves into worse bleeding and it goes to the ventricles, it's called intraventricular bleed. And that's horrible because the ventricular system is where the brain is comfortable. And if there's blood in the ventricles, khalas, there's no more areas of comfort. The brain can easily herniate. Okay? And finally, remember some of the things we just learned. What do you notice in this image? Eyes are deviated. So remember which one had eye deviation? ACA, MCA, PCA. MCA. So the deviation looks at where? The opposite side, or in the brain it would look at the lesion, or it tells you, it's a cheat code, it tells you where the blockage is. Can you see the blockage?
Yes.
What's it called here? Where is it?
Right.
This one? Who says it's this? Okay. Who says it's something else?
It's the thing about
This one? What do we call it? Hyperdense sign. Do you have hyperdensity arm? No. So it's an early sign. So we call this early. So this is a hyperdense sign. The eyes are deviated towards the MCA, and it tells you that there's a blockage in the MCA, and you can just go ahead and take it out. But what is this? And we know in the CT, we have very white things are either bone or blood. Is this bone? Oh, there's no bone in that region, and is this blood? No. Why is it blood? And it's a small dot, it's less likely, so it doesn't really make sense that this area would just bleed out this way. Calcification. So a third white thing in the brain, somatic good. So calcification is the third thing that we find in brains, especially in the elderly population. You have normal calcifications, and you have pathological calcification. Pathological is usually when the patient has endocrine diseases or thyroid diseases, so they have more calcium deposits in the brain. And generally that's it. So just real quick, we know how strokes, big strokes, the ACA, PCA, and MCA look clinically and how they look radiologically. We know that when we see a star-like pattern, this is a thrombus that came from the heart and shattered and went from the ICA to both sides. We know the TOS criteria, which is basically a large vessel where it has a thrombi, or cardioembolism, where it comes from the heart, or small vessel, where it comes from chronic diseases. And we know how they appear. We know the signs of early signs of stroke, and we know how to see it. If they show us in the exam, we know how to see it as it appears. And we know the right and the left. We don't make that mistake. We know that DWI is for time-based assessment. This is the only thing you need to know. That DWI helps me know the age of the stroke, and we know that the eye deviation goes and looks at the lesion, and we know how the ICH happens. It basically is a blood in one of the territories, and it can evolve to go into the ventricles, and the MCA can evolve to be a malignant MCA. Okay, and that's it. يعطيكم العافية.